Aortic stenosis. Aortic means aorta or aortic wall, and stenosis means narrowing. This aortic stenosis can be supravalvular, valvular, and or subvalvular. This is normal aortic valve. You can see there are three curves and it's in closed position. This is normal valve in open position, and this is area of the valve. This area is normally about 3 to 4 centimeter squared, and this can be easily calculated from this formula, but normally this is not calculated from this formula. This is calculated from echocardiography, and this you can see this is a stenosed closed aortic valve, and this is a stenosed open aortic valve, and you can see area is greatly reduced in this valve, and this can there can be further reduction in area of the valve. This can become very small, and less than 1 centimeter square is called severe aortic stenosis. Etiology, in developing countries, usually aortic stenosis is due to rheumatic fever. In rheumatic fever, there is commissural fusion. In all three commissures, there will be fusion, and there will be reduction in aortic valve area, and this is usually commonly due to rheumatic fever in our countries, and congenitally it can be due to bicuspid or unicuspid valve, and in old age this is due to calcification and fibrosis of the aortic valve. This is calcification and fibrotic valve, and sometimes it can happen due to mediastinal radiation. Hemodynamics. You see there, this is aortic valve and this is narrow, so there will be a pressure gradient across this valve. Less pressure in aorta and high pressure in left ventricle. Left ventricle is working against high pressure. So what will happen? There will be hypertrophy of left ventricle, and systole will be prolonged. Due to prolongation in systolic time, this aortic component of second heart sound will be delayed, or it will happen with pulmonary part. So there will be reverse splitting of the second heart sound, and there will be a murmur, systolic murmur, and this systolic murmur will be heard in aortic area in right second intercostal space, and this murmur will radiate to the carotids, and you can easily hear this murmur in neck of the patient, and this murmur will be accompanied by a thrill, and there will be post-stenotic dilatation of the aorta, and there will, and due to this left ventricle is working against high pressure, so there will be hypertrophy of left ventricle, and there will be reduction in compliance of the left ventricle. Due to reduction in compliance, uh, uh, left atrium will work against high pressure, and so there will be hypertrophy of left atrium, and we know this ventricular filling, late ventricular filling, is due to atrial contraction, and so there will be audible uh, S4 at the apex of the heart, and later on this ventricle can dilate also. After many years this ventricle can dilate, and due to dilatation of ventricle we can hear S3 at the apex, and due to dilatation of this left ventricle there will be increase in left end diastolic pressure and volume. So this end diastolic pressure and volume will be transmitted to left atrium, and it will again go back to pulmonary vein and arteries. Due to rise in pulmonary pressure there can be pulmonary edema, and this pulmonary part of the second heart sound may be accentuated, and this increase in pulmonary pressure can lead to right ventricular hypertrophy, and later on in late stage of aortic stenosis, this right ventricle can dilate, and due to dilatation of right ventricle, there can be increase in jugular venous pressure, and there can be ascites and hepatomegaly and edema in dependent part. Clinical features: patient with mild and moderate AS may be asymptomatic. Severe AS has three cardinal features: syncope, dyspnea, and angina on exertion. Syncope is unconsciousness for short duration, and it usually happens due to hypotension. Exerting muscles has vasodilation, and so there is hypotension. And dyspnea is due to pulmonary hypertension, and angina is due to uh, hypertrophy. Left ventricular hypertrophy, there is increase in muscle mass and oxygen supply is limited, so there is angina. And pulse will be parvus et tardis. Parvis means big and tardis means slow. Pulse will be slow rising, and peak will be lesser than the normal pulse. And so this pulse will be parvus et tardis, and apical impulse will be heaving, and there will be a systolic thrill in second right intercostal space. S1 will be normal and S2 will be delayed, and there will be third and fourth heart sound audible at the apex of the heart. There will be a ejection click at the start of systole, and this systole will be followed by a systolic murmur. This will be crescendo decrescendo murmur, and it will radiate to the carotid. You see, this is S1, and after some time after S1, this murmur will start, and it will increase gradually, and it will be peak during middle of the systole, and it will decline again, and before S2, sometime before S2, it will stop. This is crescendo decrescendo murmur. And in subvalvular aortic stenosis, there will be a murmur in left third or fourth interspace. And in supravalvular aortic stenosis, supravalvular aortic stenosis will be associated with uh, Williams syndrome. Investigations: chest X-ray. Initially, there is no cardiomegaly, and there will be dilated proximal ascending aorta. We may see calcification in aortic wall, and lately there will be cardiac enlargement due to left ventricular dilatation, and there may be features of pulmonary congestion, and due to pulmonary hypertension there may be enlargement of left atrium, pulmonary artery, and right ventricle. ECG, there will be features of left ventricular hypertrophy and strain. ST segment will be depressed, and T wave will be inverted. Echocardiography will give us full information. We can see commissural fusion, thickening, calcification, and reduced valve opening of leaflets. And we can see left ventricular hypertrophy. And Doppler will give uh, information about pressure gradients and valve area. And from echocardiography, we can see left ventricular dilatation and contraction, and we can see type of valve. Is it bicuspid or unicuspid? And we can see type of aortic stenosis also. Is it supravalvular, valvular, or subvalvular? Treatment: avoid strenuous physical activity. This strenuous physical activity can lead to death of the patient, and dehydration. Dehydration will further drop BP of the patient. Balloon valvoplasty is especially important in rheumatic aortic stenosis. And transcatheter aortic valve replacement, and this is new therapy. And aortic valve repair and replacement, this is commonly done. Prosthetic aortic valve, they are mechanical and bioprosthetic. Mechanical valves are thrombogenic, so in mechanical valves we have to use anticoagulants for lifetime, but it will last longer. So this mechanical valve can be used in younger patients. And this bioprosthetic or tissue valve is animal in origin, and this is non-thrombogenic, but it lasts for shorter period, a bit shorter than mechanical valves.